It's an incredible privilege to really be sharing this stage with some of the intellectual giants who've gone before and will follow me. And I think it's a little unnerving to be sandwiched, in particular in the program, between Lord May and Sir Peter. And I don't know whether Paul deliberately planned this as a light relief between these two heavyweights. But he certainly gave me a very clear steer on what he wanted me to speak about, which was really about the work that I've been doing predominantly in India on trials to improve access to care for people with mental health interventions. But I thought as I was preparing this talk that my talk could also extend, as we heard in the morning, looking at new roles for epidemiology in my own work, addressing health conditions that have been traditionally neglected in global health, particularly mental disorders, but also applying epidemiological methods and tools to design and evaluate interventions whose primary focus is to improve access to evidence-based treatments. Now, in John Snow's time, the disease Black Death would have been extremely familiar to him and his ilk, but probably not the disease Black Dog. And it's certainly in the parts that I come from, we usually celebrate the 200th birthday party of a person with a cartoon, and I'm going to show you a wonderful short film that probably describes the Black Dog, the features of this creature and its treatment better than any other evidence that I could present.
I had a black dog. His name was Depression. Whenever the black dog made an appearance, I felt empty and life just seemed to slow down. He could surprise me with a visit for no reason or occasion. The black dog made me look and feel older than my years. When the rest of the world seemed to be enjoying life, I could only see it through the black dog. Activities that usually brought me pleasure suddenly ceased to. He liked to ruin my appetite. He chewed up my memory and my ability to concentrate. Doing anything or going anywhere with the black dog required superhuman strength. At social occasions, he'd sniff out what confidence I had and chase it away. My biggest fear was being found out. I worried that people would judge me. Because of the shame and stigma of the black dog, I was constantly worried that I'd be found out. So I invested vast amounts of energy into covering him up. Keeping up an emotional lie is exhausting. Black Dog could make me think and say negative things. He could make me irritable and difficult to be around. He would take my love and bury my intimacy. He loved nothing more than to wake me up with highly repetitive and negative thinking. He also liked to remind me how exhausted I was going to be the next day. Having a black dog in your life isn't so much about feeling a bit down, sad or blue. At its worst, it's about being devoid of feeling altogether. As I got older, the black dog got bigger and he started hanging around all the time. I'd chase him off with whatever I thought might send him running. But more often than not, he'd come out on top. Going down became easier than getting up again. So I became rather good at self-medication, which never really helped. Eventually, I felt totally isolated from everything and everyone. The black dog had finally succeeded in hijacking my life. When you lose all joy in life, you can begin to question what the point of it is. Thankfully, this was the time that I sought professional help. This was my first step towards recovery and a major turning point in my life. I learned that it doesn't matter who you are, the black dog affects millions and millions of people. It is an equal opportunity mongrel. I also learned that there was no silver bullet or magic pill. Medication can help some, and others might need a different approach altogether. I also learned that being emotionally genuine and authentic to those who are close to you can be an absolute game changer. Most importantly, I learned not to be afraid of the black dog, and I taught him a few new tricks of my own. The more tired and stressed you are, the louder he barks. So it's important to learn how to quiet your mind. It's been clinically proven that regular exercise can be as effective for treating mild to moderate depression as antidepressants. So go for a walk or a run and leave the muck behind. Keep a mood journal. Getting your thoughts on paper can be cathartic and often insightful. Also keep track of the things that you have to be grateful for. The most important thing to remember is that no matter how bad it gets, if you take the right steps, talk to the right people, black dog days can and will pass. I wouldn't say that I'm grateful for the black dog, but he's been an incredible teacher. He forced me to re-evaluate and simplify my life. I learnt that rather than running away from my problems, it's better to embrace them. The black dog may always be part of my life, but he'll never be the beast that he was. We have an understanding. I've learned through knowledge, patience, discipline and humour, the worst black dog can be made to heal. If you're in difficulty, never be afraid to ask for help. There is absolutely no shame in doing so. The only shame is missing out on life.
So, of course, we don't call this the black dog in my business, we call it depression. And what is the evidence, what's the epidemiology of depression from a global perspective? Well, it's summarized on this slide. It's one of the commonest, in fact, the commonest of all the mental health conditions, especially in primary care settings. It's associated with an enormous amount of disability and premature mortality, particularly through suicide. It has a profound impact on people living around you. For example, the newborn child of a mother who's depressed is more likely to be stunted and underweight. And it has also profound interconnections with other important global health conditions, such as cardiovascular disease. The good news is, as you saw on that video, is that we actually do have solutions that can help the majority of people with this condition recover. The World Health Organization's MHGAP initiative tried to synthesize carried out systematic reviews to look at what treatments worked and produced this particular package for depression. A combination typically of psychological treatments, low-intensity treatments like psychoeducation that everyone should receive, more high-intensity structured treatments like cognitive behavior therapy for people who are more severely depressed, antidepressant medication particularly for people who are moderately to severely depressed, and pretty much for everyone some kind of social intervention because social factors often coexist with this syndrome. Now, in spite of all this evidence, the epidemiological evidence of the burden and the effect of treatments, the reality is that actually the vast majority of the world's people who suffer from this condition don't actually access these treatments. So this slide comes from the World Mental Health Surveys. And what it shows is the availability or access to treatment for depression in a number of different countries of the world. If you look at the top of the slide, you will see that in the low and middle income countries of the world, about 70% of people with depression have received no treatment at all for their condition. But what's actually quite astonishing is that even in the richest countries of the world, that number is not insignificant. 40 to 50% in countries in Europe and North America. When you do actually have depression and seek help, this is what typically happens. You pop along to your primary healthcare center or to your general practitioner, and there, of course, you will not get a diagnosis of this condition. In part, that's one of the challenges of trials with this particular disorder. Less than about a third of the actual morbidity is in fact recognized, and instead of the evidence-based treatments that I presented a few moments ago, typically the physician will prescribe to you a cocktail of pills. The most common pill of all is a sleeping pill, which is by far and away the most common psychotropic drug prescribed in the world today. The other very common prescription, certainly in India, is vitamins and tonics. It's a folk remedy that practitioners use. This is, of course, to boost your energy because you're feeling very tired. Vitamins and tonics account for 40% of all prescriptions in India today. Not surprisingly, a lot of people remain ill for long periods of time. They consult a lot of other practitioners, both in the complementary and alternative sector, and often have investigations done unnecessarily. Thankfully, though, depression is a remitting disorder. People will ultimately get better even on their own, but they will take a long time getting there. Now, there are many barriers to care for this condition. These are the three principal ones that I've had to address in thinking about how one fashions interventions for this condition. Interventions primarily seeking to improve access to those evidence-based treatments. First and foremost, of course, is the extremely different concepts that people have for mental health problems, in particular depression, in different parts of the world. Certainly, very few people in most parts of the world conceptualize this as a mental illness. This is, of course, related to the second important point here on the slide, is that mental illness itself as a category is associated with enormous stigma. So you clearly don't want to have a diagnosis that might actually act as a further burden to your life. But the third and very critically important barrier is the lack of available skilled human resources. Now, when we think of mental health care, the first human resource we normally think of is a mental health professional, such as a psychiatrist. And that's typically how health systems in the developing world have also thought about mental health care. But when we do that, we hit a real big problem. Here's the population of the country where I work in, 1.2 billion people. Now imagine for a moment if I applied the ratio of the number of psychiatrists in this country to the population of India, one would expect to have about 150,000 psychiatrists in India. The truth of the matter is, of course, we have a minuscule fraction of that number of psychiatrists. There are actually more Indian psychiatrists probably in Britain than there are in India itself. Now, obviously, the point here is that any mental health care system that is going to be led by mental health care professionals is doomed from the start. Now, of course, this issue of the lack of availability of skilled human resources is not unique to the mental health field. In fact, this has been a problem that many other areas of global health have had to tackle from much before the mental health field became prominent. And so I kind of looked around in the global health world, particularly in India, and looked for innovations in which these shortages of human resources had been addressed. And I came across this woman, Anjana. She is a community health worker in central India who has been trained to diagnose and treat newborn sepsis, a whole range of different infectious conditions in the newborn that account for about 40 to 50% of all newborn deaths in India. It turned out I actually visited her house a few months ago, but I actually heard about her work more than a decade ago. Anjana and women like her were trained to deliver this intervention, and then this particular intervention was evaluated in a cluster randomized controlled trial in a paper that became one of the most significant publications in The Lancet, and this particular trial reported a 30 to 40% reduction in newborn mortality with women like Anjana. This particular trial was then replicated 5 times over in different sites in India and also abroad. And today, 1 million women like Anjana roam the villages of India, providing what's called the home-based newborn care package. Now, I was very inspired by this kind of innovation that was happening in other areas of health, inspired enough to write this book, Where There's No Psychiatrist, shamelessly copying, of course, the classic Where There's No Doctor, and found very, very healthy markets for this book in many countries of the world. Unfortunately, there was no market at the school where my line manager informed me that actually this didn't count for the RAE, and I had to pretty much get down to some more serious business of actually doing some science rather than writing manuals. The good news is that we now actually do have the science to back up the idea that you can deliver these seemingly complex interventions in the hands of appropriately trained community health workers. I want to share with you 3 examples of such trials, the third one being the trial that I ran in India, which I'll talk about in more detail. The first trial was run by Paul Bolton and his colleagues in southern Uganda in an area with a very high HIV epidemic, where they trained villagers in the intervention clusters to deliver a psychological treatment called interpersonal therapy. The trial showed 90+% recovery rates in the intervention clusters compared to 45% in the comparison clusters. The second trial was run in rural Pakistan, in which Atif Rahman and his colleagues trained lady health visitors, these are routine workers in the maternal healthcare system, in fact women just like Anjana, to deliver a cognitive behavior therapy inspired intervention, and again showed dramatic differences in the recovery rates in the intervention clusters as compared to the comparison clusters. The third trial was our own trial in Goa in India, which in fact I'm going to describe in a little bit more detail. The objective of this trial, the MANUS trial, was to evaluate the effectiveness of a lay health worker-led collaborative step care intervention. Very big words. Psychiatrists love these big terminologies, but I'm going to try and break that down in a moment. For the treatment of common mental disorders, which is really depression and anxiety, because these two often coexist in primary healthcare settings. Now in India, about 60% of primary healthcare is provided in the private sector. This sector has been traditionally never included in trials, and so we explicitly wanted to actually examine the effectiveness of this intervention in both of these different important health sectors. Yeah, now some of you may be wondering about this place, Goa, India, and I think some of you may wonder really, could there be sadness and misery in that place? But actually, if you remember from the video, the black dog is an equal opportunity mongrel, and there are lots of depressed people in Goa as well. So it was a cluster randomized trial in 2 different phases. The first phase was in the public primary healthcare setting. These are essentially clinics in which you will have very large numbers of patients, very short consultation times, virtually no privacy or dignity in your consultation, and you're likely to see a different physician each time you go. And the second sector was the private general practitioner sector. This is a fee-paying service, and in other respects actually quite similar to the kind of GP sector that you might see in Britain. We had the comparison arm consisted of what we would call enhanced usual care. Enhanced in two particular ways. Firstly, because we were actually diagnosing people using a brief screening questionnaire. This is the most cost-effective way to diagnose this disorder in primary care. And then we were reporting these results to the doctor, so the doctor actually knew this is not something he would have normally known, that whether the person had a depressive or anxiety disorder, and they were provided with guidelines that were linked to these diagnostic results. So this is pretty much much more than what you would consider usual care in primary care settings in most parts of the world. Now here's the collaborative step care intervention, an intervention that really consisted of several steps. This is very typical of chronic disease management, in which you are allocating interventions according to the needs of the individual patient, usually reserving the more resource-intensive interventions for those at a greater level of need. So as you can see on this particular figure, a person receiving antidepressants or a psychological treatment would need to be at a higher step than a low-intensity psychological educational intervention. And typically that would be because they didn't respond to the lower step or that they had more severe symptoms. A very important part of this entire collaborative framework of care was the involvement of two additional key personnel in the primary healthcare team. So, of course, you always had the primary care doctor, whose primary role was the prescription of antidepressants for moderately severely depressed individuals. But then we added two new people to the mix, a lay health counselor, a layperson recruited from the local community who provided a range of case management and psychosocial interventions, also adherence support for those who received antidepressants. This is a very typical kind of role that a chronic disease health worker would play. And then you had a part-time visiting psychiatrist whose real role was to support the primary healthcare team and to do supervision of the lay health worker. So these are some images that really show the intervention being delivered. Pretty much all these images show the collaborative emphasis, the collaborative heart of the intervention. For example, the top right-hand side here, you can see a psychiatrist in the team supervising a lay health worker on the left-hand side. And similarly, the psychiatrist spending some time going through patient notes with the primary care doctor to review the appropriate use of medication. So we have published several papers. I'm going to only present the main findings from our longitudinal analysis. Now, of course, for the people who follow me, they'll be astonished to hear that actually this is the largest trial in psychiatry in the developing world. And I'm sure both Richard and Ian will think this is piffle. But this also speaks to the real challenges of running psychiatric trials. The two real big challenges. The first one, of course, is the fact that to identify individuals and to measure their outcomes, their primary outcomes, involves very laborious, resource-intensive, face-to-face interviews, especially in low literacy populations. And the second very important challenge, of course, is that the nature of the disorder itself, the stigma and different understandings of the illness, often act as an impediment to participation in the trial. Nevertheless, we were able to recruit the number of people we had originally wanted to recruit, and I think we managed to follow our people quite well. Now I'm going to present the results for the two different sectors separately, because actually the findings were quite different. In the public facilities, to use a cricketing metaphor, I think we scored a boundary. We did pretty well with reduction in prevalence rates, reduction in suicide attempt rates, and very importantly for this very disabling condition, significant reductions in the number of days that a person was out of work. And this is a very important finding from an economic point of view, which I'll present in a moment. However, the private facilities showed no effect at all. Now, I'd like to spend a couple of moments for you to think about why that might have been the case. Was it because the general practitioner usual care arm did better, or because the general practitioner intervention arm with the lay health counselor didn't do as well as the primary health care? I think you probably guessed it. It is almost certainly because the usual care GPs, damn them, did actually very well. They did as well as the control arm GP clusters where we had a lay health counselor. Now, we sort of did think a lot and mull a lot about why we had this differential site effect. And I think the most likely explanation is that we had a very non-representative sample of GPs. The reason for this was that whereas the primary healthcare centers had been selected randomly from the government's list of PHCs, so we had a single window of clearance to actually recruit any PHC we wanted randomly, GPs are individual private businesses, and we had to actually approach each GP individually, and of the 800 in the state, we managed to only secure about 20 who agreed to be part in the trial. So clearly a very important lesson in trial design is making sure that one has a very representative sample of clusters, or else you'll end up with this sort of result, which becomes very hard to interpret. So my hypothesis is, and it's just a hypothesis, is that these private practitioners provided very high quality, motivated mental health care already, and we couldn't improve upon that. The economics, well, the economic analysis showed that in both the private and the public sector, the intervention was associated with reduced healthcare costs, and this was in spite of the additional investment of the lay health counselor's salary, training, and the supervision by the psychiatrist. Now, you might wonder how that would happen. Well, that happened because the people who were depressed and received this intervention got better quicker, but most importantly, were not seeing other healthcare workers and were using fewer inappropriate medicines and fewer unnecessary investigations. Thus, in the primary health center sector, where the intervention was both effective but also cheaper in economic terms, it's a no-brainer. It was dominant in cost-effectiveness terms. So the key messages of this trial were that in the primary healthcare sector, it seems that this collaborative care model led by a lay health worker case manager in primary health centers produced a number of different benefits, a number of different outcomes were improved in people with common mental disorders, and in fact the intervention led to lower healthcare costs as well. But in the private sector, it seems just providing doctors with a diagnostic result and with appropriate training, you could achieve very similar outcomes. So the next step, as I finish, is that, first of all, to summarize that for the black dog, one of the leading conditions in the mental health sector in terms of the burden of disease, we know what works. We now have modest evidence, I say modest because 3 to 4 trials is all that we have currently, on how we can deliver these evidence-based treatments in real-world settings using non-specialist workers. The next and final step is really to scale up what we do know works and to continue to build evidence to strengthen the knowledge on how to deliver these evidence-based treatments. In the scaling up area, there's some very exciting stuff happening. Governments, particularly those of middle-income countries who now have more of their own resources to invest in the health sector, are beginning to actually greatly expand investment in mental health. I've been very fortunate to be involved with the Ministry of Health in India to draft India's new national mental health program. And in fact, one of the most exciting things in that new program is the incorporation of a completely new cadre of women like Anjana, who works in the maternal and newborn health field, but to work in the non-communicable disease field, and that will include mental health care. In terms of strengthening the evidence base, a couple of years ago, the NIH led the 3rd edition of the Grand Challenges Research Priority Setting Initiative. This was focused on global mental health. And what was very interesting is that of the top 40 challenges, the top 10 were all implementation challenges. They were not about discovering causes of mental disorders or discovering new treatments. It was really discovering how you deliver the things that you already know work and most people can't access. And so clearly this kind of implementation science now has great backing from some of the leading research funders in the world. In fact, in the last year alone, about $70 million to support many groups in the South to carry out this kind of work. So in the end, what have I tried to do is just to hopefully show that epidemiology can play a profoundly important role in improving access to evidence-based care, oftentimes for conditions that have been historically neglected in global health, but also in so doing to reduce global health inequalities. Just want to finish off by thanking the government of Goa, with whom I've collaborated for more than 15 years, and of course the Wellcome Trust that supported my work for 15 years. Thank you.